for me to get the recording started. We are officially on record. Please use your mute button. We do use the mute all, but there are some, for whatever reason, that I'm unable to mute. So please keep in mind that we want to keep this interactive. We want to enable everyone to be able to unmute themselves, but please refrain if you're not sharing or speaking, so we can limit the background noise. Call-in users, if you would take a moment to right-click your name in the participants list and rename yourself. We'd love to know who we're talking to. Please type your name and organization in the chat if you haven't already done so, so we're able to see who's joining us today. And feel free to add your pronouns to your introduction. We'll be monitoring the chat, so you're welcome to engage and ask questions. We'll try to keep a close eye on those. And when we can introduce the questions into our conversation, we'll be happy to do so. So without further ado, I'll turn it back over to Lori.
Diana Boyer and Jessica Haspel. The agenda disappeared. But after that, we will be hearing from the folks in Sacramento about their program, The Source, and then moving on to hear some information from Monterey County Behavioral Health, as well as the Seneca folks. It should be Seneca family of agencies. I just noticed we had a little oops on our agenda. Anyway, those folks will be giving us some information about their programs. And then we're going to hear from a couple of people in the Bay Area. They are looking to do a regional approach, and they've actually been meeting for many, many months. And so that I'm sure they have a lot of great information to share about both what things work, as well as a few roadblocks that they have come across that they can share with others, so you can avoid them in some of your county plans. And then we'll be just talking a little bit about a few resources that we've mentioned in other webinars, and then opening it up for questions. So I am now going to turn it over. Is it important? Can I call you back? Well, is it quick? We're going to get everybody muted again. And I'm going to turn over now to Diana Boyer and
Thanks, Jennifer and Lori. Yeah, I think when Jennifer muted all, she muted you just momentarily there. So Diana Boyer with CWDA. I am listed on this webinar as CWDA host because we have kind of a funky setup with our WebEx. I am not the host, so thank you, CDSS, for hosting. I just want to kick it off before I turn it over to Jessica Haspel that CWDA is really happy to bring the county agencies together in this way. We're really thankful for CDSS to put this on actually fairly quickly. This came out of a request from our last September Children's Committee meeting, CWDA meeting in September, that we wanted to hear from those counties in the state that have implemented a family urgent response system. I just want to remind folks, I guess, if you will, I think we have a lot of new folks that I don't know everybody on the call. We have other agencies besides the county welfare departments that CWDA was a co-sponsor of this legislation. We were very proud to be able to co-sponsor this, the bill that brought about FURS with Children Now. You'll be hearing from Jessica in a minute. SCIU, CBHDA, the Seneca family of agencies, California Alliance of Caregivers, and others. This was truly a monumentous bill because of so many agencies that came together and stakeholders in support of what is a practice that we felt was a missing piece to implementation of the Continuum of Care Reform, or CCR. We knew that families needed the support, the tangible supports, the youth needed those tangible supports. They needed them in the homes, and they needed them in a timely way. and in a unique way that really the system wasn't quite ready yet on a statewide basis to implement. And so we went out, we first heard from colleagues in New Jersey. New Jersey implemented a response system very similar to how ours is modeled, that was found to reduce entries into group home care. It was based on, in New Jersey, a very broad reform effort, very similar to ours in California, that recognized the importance of services to families and children in the home at an early point before it led to a crisis, if you will, a true mental health crisis in the typical, I guess, verbiage of it. This is a response that was intended to be family friendly, supportive, timely, statewide, as well as county based. And so you're going to hear a little bit about what the bill entails, very high level summary. I would encourage folks, if you haven't yet, there is an off-county letter, ACL 2089, that goes into great amount of detail about what the program is supposed to be. And Jessica will provide a bit of an overview as well. And then we'll really get into some nuts and bolts about how counties have approached it. We did also reach out to some of the counties that you have on the call here to ask them what their approach has been or what they felt like was needed in informing our legislation and California's FURS system development. So with that, I'll go ahead and turn it over to my colleague, Jessica, who we're really pleased to have been able to work with her over the last, 2 or 3 years, I think, in setting up the FURS program.
Thanks, Diana. And I'm going to try and keep this not too long as well, just an overview so that we can get into the meat of things and you can hear from programs that are operating now. I don't generally like to read from slides, but I do think it's important in terms of orientating ourselves to hear what the definition of FURS is that's in statute. So I am going to just for this slide read it to you. And FURS, the Family Urgent Response System, means a coordinated statewide, regional, and county level system designed to provide collaborative and timely state level phone-based response and county level in-home, in-person mobile response during situations of instability for purposes of preserving the relationship of the caregiver and the child or youth, providing developmentally appropriate relationship conflict management and resolution skills, stabilizing the living situation, mitigating the distress of the caregiver or child or youth, connecting the caregiver and child or youth to the existing array of services, and promoting a healthy and healing environment for children, youth, and families. And I'm going to unpack that a little bit on the next slide when we talk sort of what the goals were behind FURS, which Diana has already touched on, but I'm just going to highlight additional things. So if we can move to the next slide. As Diana mentioned, the intent behind FURS was to build on continuum of care reform and make sure that our youth and caregivers were having access to immediate trauma-informed support when they need it. And we really wanted to prevent placement disruptions, preserve relationships, prevent calls to 911 and hospitalizations, promote healing, retention of caregivers, and stability. So it's very broad in that sense as far as the aims of what we're trying to achieve, which is really see through. And in the ACL, if you haven't already reviewed them, a lot of language about healing and relationship preservation. So we were coming at it from the standpoint of really wanting to make sure that we were providing the supports when the youth or caregiver themselves identified they needed something and they weren't able to get it through something else. I think that's just really important. One of the big things that when we were developing this was we want it to be, and it's intended to be, a resource for youth just as much as for caregivers. So a youth themselves can reach out and ask for the support when they need it. There's not criteria around having to meet sort of clinical level of need in order to get the support. Again, that was the goal of it being, very family friendly and just looking at it from the lens of wanting to help families sort of navigate their own needs with, recognizing the trauma that the youth have experienced in the past. And again, it's intended to fill a gap. So we recognize there's resources that exist already, but they don't, as Diana mentioned, necessarily exist consistently or statewide or as broadly. And so the goal is to be able to provide this as a resource, and then connect to longer term resources that are in the community that exist if the family isn't already. The other thing I just would say is that while this passed last year and we've been working towards implementing it, I think all of the co-sponsors of FURS recognize how important this is, also in the context of COVID, and in the context of the additional stress and anxiety that families are facing. Additionally, I think it's very timely, and one of the goals of FURS has been to give an alternative. Oftentimes in the past, when families haven't felt like they had somewhere else to call, 911 or law enforcement got involved, and that's not a very trauma-informed response. And I think in light of everything that we're seeing in the racial justice movement and movement towards moving towards alternatives to law enforcement, I think FURS is really, is a piece of that that's really important. With that, I guess I will have you move to the next slide. And so I'm not going to go in depth about this, but just want to highlight, which I hope everyone is familiar with, that FURS consists of two particular components. One is this 24/7 statewide hotline for the youth or caregiver to be able to reach out to during situations of instability, and the other being county-based mobile response and stabilization teams that are also available 24/7. I think what's really important around this is when we were building the legislation and hearing from folks, was this idea that we really needed a central place for people to be able to call, because it's very difficult often when a situation comes up to know who to turn to. And we wanted there to be sort of a central place to receive that support. And the statewide hotline is intended to really provide de-escalation and a place to listen and try and help provide the caller with the support they need then. So the expectation is that not all situations are going to need to be referred for a mobile response at the county level, that's a resource that's going to be available when the caller doesn't get enough of what they need just from a phone response. So I think that's just important to know, is that not every call that comes in to FURS is expected to then get sent down to the county. It's really supposed to get some intensive de-escalation help, someone to listen to, some triaging, and then that sort of warm handoff if that additional support is needed. So that, I know, again, Diana referenced the ACL, and CDSS may talk a little bit more, but that's just very high level what I wanted to highlight about FURS before we get into some of the other programs. And so with that, I turn it back over to, I think it's Lori next.
Thanks, Jessica. Before we actually get started with hearing about the specific programs, just wanted to reiterate, Jessica and Diana also alluded to this, but wanted to be very clear that the programs you're going to hear about today are what we're calling FURS-like. In other words, most of them, have been developed for similar reasons in some of the different county systems, and are not necessarily the same as a mental health response. However, they do vary. You're going to hear a number of different, combinations of players that are part of these teams. And so just wanted to kind of put that out there, that you're going to get a lot of good information about putting together programs. But please note, none of them are exactly like, what's required in FURS. As, Jessica just, there's two components to FURS, with a statewide hotline that's separate from the mobile response at the county level. Some of the programs you're going to be hearing about today, it's a one-stop kind of response. Just wanted to point that out. At this point, we haven't, received any county plans yet, so there's not any FURS programs running yet. So with that, I'm going to go ahead and turn it over to David and Christina, and they're going to talk about their program through the Sacramento Children's Home. David or Christina, go ahead.
Yes. Oh, so hello. Thanks for having us, and I appreciate you saying that we're not exactly the same as what's being proposed for the FURS. We're actually a behavioral health contract focused on mental health crisis, but there's a pretty big crossover. I can't control the slides, so I'll just say next slide. This is a presentation. We were going to start with just talking a little bit about the program and what we do, and the slides, I'll skip some of them just so you know. This is because sometimes we do a much longer one, and then get into some of the things that we've learned. So if you can go to the next slide, a little bit about the source. The 24/7, 365-day program that serves all youth under age 26 and their families or caregivers. So we have a priority that is given to foster youth, and we have a focus on foster youth. When the program started, we were just for foster youth, but we have been able to work with Christina and the county and expand that to serve a lot of other youth in the county. But we have a priority on foster youth, and we have a foster youth youth council, and we do respite care and some other stuff that's just for foster youth, in addition to the calls that we take. So go ahead and skip. Go to the next one. You can skip the next two. These are just to know that our program actually started with Mental Health Service Act dollars and has sort of morphed into Mental Health Service Act dollars. Medi-Cal dollars as also. You can go to the next one, and also we have another grant as well. I'm blanking on it. Christina, if you know, you can. I'll have those moments. Oh, a chapel grant. Sorry. Chapel grant. So, and so what we do know, and we started with foster youth, and we have a focus on foster youth, is that they need support, and that there are definitely challenging times, and sometimes having somebody to reach out to. And what we learned early on was that once we had our number out there, our number's 916 support. Once we had it out there, we were getting calls from other folks too. So a lot of them shared some of the same sort of needs and supports again, but many of the youth that we still serve is foster youth, and we have had. So if something that we have learned, I know that was one of the things, is that when we're trying to reach foster youth specifically, it's been very important to connect us to foster parents early on. So we've been working with the county and getting, when there's a new placement made and that sort of stuff, social workers provide this information about how to reach us and what services we can provide to foster youth when everything's going well, to the foster youth and to the foster families. That's been probably the best. We do a lot of marketing and that sort of thing, but probably the best way to reach is to have social workers and foster family agencies giving this information to parents when everything's good, so that hopefully they remember to call when they are struggling. You can go to the next slide. And that's something that we learned early on was the folks that we're really trying to target, you have to kind of reach them and let them know that you're there, and have that set up. You can go to the next slide. This just talks about the number of kids that we're looking at across Sacramento. And so we have different ways to reach us. One thing that we have found that's super important is that there's not just, for us, has been that not only do we have the 24/7 phone call, but you can also text, and through our website, you also have a live chat, because as we know, a lot of the youth prefer to text or chat rather than call. Next slide. Like I said, and for us, everybody who's eligible is any youth under age 26. The caregivers for those youth, and they must reside in Sacramento County. We do get calls outside of Sacramento County from time to time, and we can provide resources and that sort of thing, but we can only go out and serve folks that live in Sacramento County. A lot of the objectives and goals of the program are focused on a response to crisis, maintaining placement for those foster youth, increasing coordination of care within other partners. So if we go out, so we take calls 24/7, but we also then dispatch folks out to help deal with what the crisis is. And so when we discharge those folks out, that generally leads to us opening a case, and we can stay with them and provide mental health services and supports for up to 30 days while we link them to long-term care. So it's not uncommon for us to be open. I think our average time is probably closer to 2 weeks while we work with the family or the child and get them linked to some longer-term care. That could be another county program, or it could be just connecting them with their their private providers as well, like Kaiser and that sort of stuff. So there's an initial de-escalation. A lot of that's going on. We're looking at trying to reduce kids having to go in for psychiatric inpatient care, and sort of what I think someone was referring to earlier, Jessica, was, and just trying to curb the use of law enforcement related to those. We can go to the next slide. Some of the examples we get calls for are youth experiencing danger to self or others, destroying property, caregivers ready to give up. And early on when we started that process, that was focused on foster youth, so foster families ready to give up, but it's not that uncommon for us to get a call from just any old parent ready to give up as well and trying to figure out who do I call to give up. We've connected with FFAs, trying to help them avoiding notices, that sort of thing. Often for violent, aggressive behaviors, agitated youth. We do get calls for youth, transitional age youth experiencing homelessness. We have some ability to, with hotel vouchers, to get them some short-term stays while we connect them with some longer-term services. A lot of referrals there. Next slide. And the different interventions that we provide are listed here. Creating safety plans, providing some respite at times, providing referrals and resources. It's not uncommon when we go out with a therapist and a youth peer mentor or a family partner, and try to create a situation where people are, talking to both sides. There's a lot of times families are just escalated into a lot of conflict. So separating them and helping both of them, coaching them through that works out pretty well. Next slide. Some other things, lots of sharing of resources. We get a lot of calls for a whole variety of resources. People looking for housing, looking for support, looking for childcare issues, looking for mental health services, that sort of thing. We get those calls from folks who qualify and folks who don't sometimes, but we certainly can provide referrals to everyone. We were getting calls for COVID through the county as well, getting people connected through that for a little while there. So the types of staff we have on-call coordinators, clinicians or therapists, youth partners, and family partners. So we have the MHRS level folks and some licensed and waivered folks, and it's really a mix. And for us, all of the folks listed here do time working, answering phones and screening calls. And it's not uncommon for somebody who answers the call to stay with the call and actually be the person that goes out and provides the service. That really helps. They've had a conversation, and unless it makes sense to do a pass off, like often it makes sense to pass off to a youth partner or pass off to a clinician. But many times the same folks will be the person going out and staying working with that child or the family. And we also try to match sometimes whatever the need is. So next slide. I talked about we have a youth advisory board. We do a lot of social media outreach, trying to reach with youth. You can find us on everything from Facebook to TikTok, and there's lots of people who are following us on there. And we try to really work with our other partners in town on building connections. So you can go to the next one. The biggest thing really that we learned too is here's some information on how you contact us. So in terms of what we've learned, like I said, we've learned that if we're going to connect with foster youth, we have to connect with those families early and often. And so we also have been able to locally get information, and we send out information from time to time. We try to get foster families to follow us on social media or to sign up for some of with their emails, so we can send information when events are happening and things like that. That's been pretty successful. We have, and I know, Jessica, you're talking about not everything leads to going out in person, and I would say that's true. We had when we started the program, we sort of start from the preference of we're going to go out unless there's a reason not to. And we thought that would mean that, that wouldn't happen that often. Most people would love for us to come out, but what we have found is even when we're desiring to come out, sometimes families just want to talk, or a big thing that comes up, which I hadn't anticipated, is they want to schedule a time for someone to come out. So while we are a crisis line and support line, sometimes they're calling to get resources and help, but that doesn't mean they want someone to come out right now. So we've been able to set up situations there. During COVID, we've transitioned more to going out when it's more of a crisis, more of a traditional crisis than just kind of trying to go out and build connections. So key to this has been really, I think, a good partnership with behavioral health, and then we've expanded that out to school districts and over on social services. And Christina, I don't know if you want to say anything about the partnership. We are working together to identify how to reach more families all the time.
Yes, Sacramento Children's Home has been very collaborative in working with our school district, our child welfare partners, and even with some of our law enforcement as well. Trying to get the word. And just again, the more that we can get folks to have this information early on, it leads to a crisis. Sacramento Children's Home really doing a wonderful job of taking that roadshow to all these different stakeholders. Another piece of that, because it is a behavioral health service program, is that they have access to our electronic health records. So any of the youth that do get escalated to an actual crisis, they are then entered into our Avatar system. And because they do have access to Avatar, they are able to view other behavioral mental health providers that the youth may be linked with. Some of our providers have a 24/7 warm line as well. So what the source can do is, if a youth is linked with a mental health provider, then back to their warm line, just so that their primary mental health provider is aware that they're seeking out these services and that they can take the primary role in providing that type of support. And again, as David mentioned, I just want to reiterate some of the unique things about this program is that they provide respite services. So what that looks like is if there is an escalation between the caregiver and the youth and they are needing somewhat of a break, the team pre-COVID could go ahead and go with the youth or the caregiver and take them out to just take a breather. Then they can reconvene again and then try to mitigate the situation further from there and provide them resources that they need. Something else that the source has done wonderfully is actually providing outreach. So webinars to help provide basic skills of just recognizing crisis. So you don't need to be a mental health professional. It can be a caregiver or a school staff member who can join these webinars and get education from the team.
Yeah, that's you brought up a good point, Christine, that I didn't hit on. Another lesson learned, and we're doing this, but I found has been very successful and helpful to clients is resource guides. I mean, we've built up a tremendous catalog, so to speak, of resources, and we have set it up so that when someone's talking to us and we want to give them resources, we can send those resources as a text or an email. So they don't have to write them down or anything. And then when they get the text or the email, they can just click on it and it links them to the to most of the resources. That it either connects them by the phone number or connects them to their website. And we have found that it's been tremendously helpful for folks to make it as easy as possible for them to have that resource available once they stop talking to us. It's not uncommon for us, I forgot to mention, like Christina said, that for us to also be able to pull up their current providers. A lot of times they don't remember their safety plan, that sort of thing. We can pull that stuff up and talk with them and reconnect them to the folks who are already providing service. So very helpful.
And just to address some of the questions, it looks like they're asking if
I wasn't looking at that.
Oh, it's okay. Teamwork, right? Yeah. Someone is asking if if all levels of staff are available to respond 24/7. And my understanding is that they are correct, David. They can even team out and go together if needed.
Yes. So the exception probably to that is on what we call the overnight or the third shift. On that case, we don't have everybody physically awake answering calls. We just have a few, and then we have a backup plan if we need it. So let's say that the person answering the phone's not a therapist, but we need a therapist to go out. We have an on-call therapist that we can call. But we have found that on the overnight hours, we don't need all of those folks to be on all of the time live. It's just, we just don't get enough calls to support that during those hours, but we have somebody available. And we can go out 24/7. And we have found that many times going out is much more helpful if you, sometimes they're teaming up a lot of times, right? So, and I know that's come up before around some of the safety issues and that sort of thing. And that's why many of the times for the evening calls or calls into certain parts of town, we send out multiple people, especially when we're first starting and there's assessments to do and all that sort of thing. And then when we're providing ongoing services, then you can kind of make a better plan for that. So some people are asking about the percentage of times that we're going out.
Yeah, I have that, David, and I want folks to keep in mind that this past fiscal year for 1920, that the source has grown very fast. So as David had mentioned initially, it was a small target population of then they expanded to all youth, and then they further expanded from up to age 21 to up to age 26. And so some of the numbers might seem low because there was a lot of transitions that occurred within the fiscal year. So to address one of the first questions as far as Medi-Cal percentage of being reimbursable, I don't have the exact percentage, but I will say for 1920, as far as the unit FFP, it was about 30,000 or 28,000 if I went around a little bit closer. In regards to percentage of in-person mobile response and data regarding calls per day and so forth, again, because there were fiscal year looking at the average calls per day, there was about I'll round it up to about 10. It was 9.32, and average total calls per month were about 290.
So just remember, Christina, on that's the calls that, well, it's complicated, but for the last 5 months, the contacts have been averaging about 508 calls or about 17 a day. Not all of them get entered into Avatar, and not all of them get entered into the other database that you sometimes gather data from. So it's anyway.
Yeah, so it looks rather. What I will say, the reason why it's pulling so low is if I'm looking at the whole fiscal year, but I will say it's averaging about 500 within like the last, towards the end of the 1920 fiscal year, because things have picked up with the expansions.
Yeah. Okay. So you're going back to, like even the day we turned the phones on and nobody even knew the number yet.
Exactly. So for the best example I can say is the highest month that they've had in the fiscal year was over 650. And then when they first started, they were in the lower 150s. And so it's grown tremendously from about like 5 calls per day to an average of 17 calls per day.
So I was trying to do a comparison. I looked at the California Youth Crisis line, and they're saying they do about 50 calls a day for the whole state. So it's been growing pretty good, I think, for considering it's just inside the county.
And then looks like there's questions about how much of those contacts are foster youth that we are still trying to calculate that data. We have a research evaluation and performance outcome team repo who extracts that information. I don't have that readily available, but that is something that they are working on. And when I had mentioned the FFP, the 28,000 is units. I don't have the dollar amount offhand, but those are units, just to get a general sense of how much was conducted at that time. But again, as David had mentioned, FFP was not incorporated into the later parts of fiscal year 1920. It wasn't initially, it was primarily MHSA funded. So if you're looking for more of data from the beginning to start of the fiscal, this probably isn't really reflective of a beginning start of July 1st. Yeah. I want to say that FFP was incorporated in January.
Yeah, it was in January, and it was also intentionally capped, if you recall. or you weren't on there, Christina, at the time, but it was intentionally capped as the program has started as a demonstration project, so we've been incorporating new parts of it. So when we added Medi-Cal, we had set a goal of, I think it was 40,000 units or something, and I think and we're going to do much more than that this year. But it's been a process of building out the program in court, along with the county, and keep adding more stuff, which is great. So. Yep.
And there's another question about how are multiple referrals at the same time addressed that may require same staff?
Yeah. So we generally have 4 staff answering the phones, and the texts and the chats, and then we have other staff that it rolls over to backups, and then the response is coordinated. So there have been times where we're out providing service to multiple. I mean, we have enough teams that we can put together to be out on, at any given time, easily 5 to 8 in-person responses at one time. The other thing is everything we do is mobile. So folks that go out, they can actually operate the entire call center from their phone or from a laptop anywhere. And so it makes it really easy if there's a team out with a family or with a child, and then they need to be dispatched from there to another or get on another call, they can do that pretty easily. It's all set up to be mobile, but on any given day we have four people that are leading those teams that are just available to answer the phone. Except for at night, we only have 2 because we don't get as many calls during that time. And it's been a process of figuring out staffing, I will say, and what times people call and how many staff you need during those times. So, and when COVID hit, it all got kind of thrown off for a little bit. Seems to be settling back to more of a norm. So, because we also ran into folks that didn't want to have any face-to-face support because they were worried about COVID. So they would want to talk to somebody on the phone or chat or that sort of thing.
Yes, because I would say that the percentage, and these are rough estimates. It looks like within the last 6 months, as far as what's resulted face-to-face is about 4%. But again, as David mentioned, a lot of folks have been really hesitant to have face-to-face contact. If I'm looking at the entire fiscal year, we're looking at about 8% of those actual contacts resulting in some sort of face-to-face. But again, these are rough estimates of what is visible in Avatar, and then counting how many of those entered into Avatar in addition to all the calls from the report. Sacramento Children's Home uses iCarol as their reporting database for all the calls.
Anyway, I don't want to take too much time if the next group, but I don't want to take away from Ken, but I'm happy to answer any questions. And someone asked about the PowerPoint. I sent it to the folks over here, and you're welcome to share that. It's fine.
Right. Thanks so much, David and Christina. I see that there's definitely a number of other questions that are coming in through the chat that perhaps you didn't get to yet. We have saved some time at the end of all the presentations so we're marking which questions didn't get answered yet, and we'll try and get to those at the end. But we do want to move on now to our next group. So if we can bring the agenda back up just to remind folks where we're at. All right, so our next presenter is Marnie from Monterey County Behavioral Health. Marnie, go ahead.
Hi, good afternoon, everyone. I'm happy to be here this afternoon. I know on the agenda, it looks like you have the Monterey County presentation slated before the presentation with Seneca, but actually we have a partnership with Seneca, so we're going to blend those two together. So as I talk about, a little bit about our journey in Monterey County, it's really interwoven with the work that Seneca is now contracted with us to do. So with that, I would definitely like to introduce Ken Barrick, who's the founder and CEO of Seneca, and also, my partner in crime and many great things that I think we're doing in Monterey County right now. So I think Ken might have a few thoughts and ideas to share with the group, and then I can definitely begin talking about our Monterey County journey.
Great, thanks, Marnie. And it's great to see so many names and some of those of you who did actually brush your hair this morning that have gone on to video. I know there might be a few of you who are not dressed appropriately for a webinar. So in any event, it's good to see there's something like 250 people on this webinar. So it's great that there's so much interest. I want to take 1 second to think about sort of the evolution of FURS and really to acknowledge the leadership from CBHDA, from Frank and Diana at the Welfare Directors Association, CWDA, and the departments, because this is a remarkable achievement that we are going to have a statewide response system, and frankly something that I wasn't sure I would see during my career, and I think we can see the evolution of how we got here when we look at the beginning on the child welfare side of starting primarily with residential treatment, moving to treatment foster care, and then watching treatment foster care evolve to wraparound. And integrated into wraparound, of course, is the assumption and the ability to do mobile response and urgent response. And what we got to see in that evolution were the limitations of having so few youth and families that had access to urgent response services, and that were able to move to be served in a more flexible way. So I'm going to actually ask folks to make sure that you're muted, if you would. As we did that, we got to see what urgent response could do, and in the best of circumstances, it can act as sort of a systemic superglue. And we've seen that time and time again as we actually moved from wraparound to mobile response, where we have the ability to bring child welfare, juvenile justice, mental health, and education together, and to be responsive, and to make sure that we can provide both initial stabilization, but perhaps more importantly, the linkages to services where they're needed. And so what we're going to do is talk about our partnership with Monterey, which is a deep partnership, and all of our mobile response efforts are linked to other systemic efforts, including particularly wraparound, and in many cases, school-based services. So, of course, we in Monterey and in the counties that we serve are generally not just doing child welfare, but in all situations, even just if it were just child welfare, it would be linked closely with wraparound and linked very closely with our work in the schools. So I think it's important to acknowledge the power that has to link those systems together, and to make sure that we're not just doing urgent response, but we're helping systems that have traditionally not worked in deep partnership be more closely linked and work together. So we're, as David said, we're stabilizing placements at home, we're stabilizing placements for youth in foster care, and we're allowing kids that might have gone into higher levels of care to be stabilized in ways that then create linkages that make the systems more durable and more connected. And with that, I'll turn back to Marnie and to our team to talk about the partnerships.
Thanks, Ken. Again, I'm Marnie Sandoval. I'm the Deputy Director of our Behavioral Health System over our Child and Adolescent System of Care. I've had an interesting vantage point. Been with the county in Monterey for a little over 20 years, and was initially hired into a position to really begin the strategic partnership with behavioral health and child welfare. So it certainly has been an interesting journey. So for the 20 years that I've been in the county, Monterey really has had an active partnership with child welfare and juvenile probation that have really included dedicated behavioral health programs to support the mental health needs of the dependents in the wards, the 300 and 600 kids. And so over the last 20 years, both of those behavioral health programs have really grown as we've become more aware that kids with complex trauma have really complex needs, and they're going to do whatever it takes to protect themselves, even if some of those behaviors end up being really maladaptive and end up resulting in placement challenges, disruptions, and then of course more trauma. So really our goal locally in Monterey was to leverage the partnerships so that we could help the kids, the families, and our agency partners in really meeting the mental health needs of the foster kids. We had been limited with resources to get in and help those kids earlier, and really by leveraging some of our MHSA funding, we've been able to think about how we could create opportunities for earlier intervention. If you could go to the next slide, please. Actually, even forward one more. Perfect. So just want to walk you a little really quickly through our journey in Monterey County. In November of 2015, Behavioral Health launched our mobile crisis program. Now that is different than what we're talking about in our mobile response team today. The mobile crisis program that was developed and launched in 2015 was created in partnership with law enforcement and was very specific to co-responding with law enforcement for call-outs that included some potential mental health component. And it was really primarily adult focused, and the response was really for that highest level of crisis acuity typically. So even at that point, it was really clear to me and our bureau that there was still a local need to have some impact on kids and reducing the amount of kids that were coming into care, the number of kids that were being hospitalized, and also the number of kids that were being criminalized. And so in 2016, in August, I really pushed for the beginning of a deep dive into understanding across the country what were other counties doing in mobile response programs for children and adolescents. And so with the help of a couple folks on our staff, we really did a pretty extensive review and completed an internal proposal in 2017 that I presented to leadership, and they felt like, okay, clearly there's a need here, and this type of program would be what might help us have some impact on the areas we're wanting to see improvements and healthier lives for the kids and youth and families in our county. So by July of 2018, we really got deep into planning our mobile response team for children and youth. And this is where discussions with Seneca really started to become very active. We knew we wanted their help with this process. And so we jointly decided to apply for a CHAFA grant, where if we were awarded, Seneca would be our provider. And so that work was a good collaboration. And by February of 2019, we submitted that CHAFA grant. And then, of course, in July of 2019, FURS became formalized. And so it was really fabulous for me personally to see that all of these efforts, over the course of nearly 5 years, were really putting us in a fabulous position to be nearly meeting the requirements of what FURS is setting out to do. So that has felt like a really good place to be in. In June of 2019, we received that CHAFA grant. It was, while we were excited, I think Seneca and ourselves at Monterey County Behavioral Health were a little bit disappointed because we only received a portion of the grant funding that we had requested. So, I had to do a little bit of financial gymnastics to figure out how we would continue to fund this program, because I wasn't willing to compromise, the intention and the design of the program. So we had to reduce the size of the number of teams we had initially planned for a little bit, but we ventured forward. And in July 13th of 2020, our mobile response team for children and youth went live. So it was very, very exciting. Next slide, please. So the funding formula for our mobile response team is a combination of a small amount from a CHAPA grant to help us get started, and then a combination of some MHSA funding under our Bureau Mobile Crisis Team program, and then, of course, leveraging Medi-Cal for FFP. Very, very new program getting started. Some basic information service data, which Cece Mendoza, who is with Seneca and is our Monterey County lead and director of clinical services here and overseeing this program, can chime in if she wants to give you some more specifics. But we have had in July, and that wasn't a full month, we had 47 calls and an additional 6 referrals. And we had, I think, let me find my numbers here. I think in that month of July, I don't think any of those resulted in hospitalizations. And then in August, we had 18 calls plus additional 10 referrals, and only 2 of those kids were hospitalized. And I believe in the month of August, we did have 10 in-home response that came out of those calls that came in. So I'm not sure, Cece, if there's anything else you want to add about that.
No, I think you covered that. We're really trying to do as much, even with COVID, some face-to-face or person support, but we're also incorporating telehealth.
Great. All right, thank you. Next slide, please. So I think really thinking about, our existing mobile response team and the similarities that it does have currently to some of the FURS requirements, that one, that we can respond to all foster kids and foster families because we're really responding county-wide. So we already have that in place. We're doing clinical triage to determine the level of need. We're having in-home response of both a clinical team and a family partner when that's needed. I think where we need to continue to work to get our FURS-like program fully up to meeting the intentions of a FURS program really are 2 key elements that we're going to have to work on, where we're establishing a full 24/7 in-person response. Cece will go into a little bit more detail of exactly how our program is structured as far as hours and response. And then, so we'll need to make sure we have that. And we also will need to formalize a protocol with child welfare and juvenile probation so that we have a contact and the ability for involvement with those 2 agency partners on a 24/7 basis. So locally, we're already working on that. So I think those are really the 2 key elements that we still need to build to get our program fully meeting the FURS requirements. So with that, I think Cece is going to take over from here and give you a little more detail about our Monterey County program.
I'm actually going to pass it on to Johanna, who is one of our program directors for our mobile response team in Contra Costa. Both of our Contra Costa and Monterey programs are very similar, and I'll have Johanna go ahead and take this part, and then I will follow up after.
Thank you, Cece. So yeah, like Cece said, we have our mobile response team in Contra Costa County that I think is currently in its 19th year. Ken, you can correct me if I'm wrong. And so there are a lot of similarities. I think the biggest difference is that Contra Costa is just bigger. We have 12 full staff clinicians. And our hours are a little bit different. But so for Monterey, there's 5 crisis clinicians, a family partner, and a program director. We also, Contra Costa County, have access to a family partner. We don't have one full-time, but it is also something that we have found super beneficial and helpful for supporting parents in particular. Also a combination of licensed eligible and licensed staff. And there's, extensive Seneca family of agency training that all of our clinicians and staff go through. Next slide. So the mobile response team's main goal is definitely to stabilize and to reduce unnecessary hospitalization and unnecessary police involvement. We want to get out there. We want to assess. We want to see if there are any natural supports that we can tap into, if there are any family or extended family or just other supports that we can tap into to stabilize the situation. We definitely want to work with the families in a culturally sensitive, family-centered, trauma-informed way to figure out what that safety plan is going to look like. It definitely has to be developed collaboratively with the families to make sure that it's going to work. Next slide.
So I already said that. We definitely want to collaborate with families. I think going back to this theme of lessons learned, I think as often as we can get invited to or infiltrate CFTs or IEPs or RAP meetings or just anything that's going to give us bigger context of what the family is going through is helpful. And so we really want to make sure that we're collaborating. We really want to make sure that we're communicating with whoever the long-term providers are. Again, it doesn't necessarily have to be just a provider. It can be natural supports. If we do come across families that are not yet linked to services, we're definitely going to work with them to figure out what they have access to, what they're eligible to, and make sure that we are linking them. And again, in Contra Costa County, our hours are 7 a.m. to 11 p.m. for in-person face-to-face. Monterey, it looks like it's a little bit different. It's from 8 a.m. to 10 p.m. And again, all of our programs have 24-hour phone support. Next slide. Is that UCC?
Yeah. So pretty much what we're really trying to do is provide services, not just for system involved youth. We want services to do a lot of the preventative work. So we want to get ahead of it before they're involved. We provide services for youth who have Medi-Cal, who are uninsured, and who are privately insured. We also want to support them. We serve youth between the ages of 0 to 21 and really trying to serve that really high risk population, which is that TAPE population, and making sure that we're providing as much support for them. We're really trying to reduce any barriers to eligibility, and that's one thing that we've learned and really tried to throughout the years since we started our mobile response team in Contra Costa. That it's changed and evolved in other counties, that when there's all these strict eligibility requirements, it restricts us in being able to serve these youth and provide that stabilization. Next slide. We want our referral process to be as easy as possible, so they could call our crisis support line. So Contra Costa has their own support line, and obviously so does Monterey County. They could email us the referrals, and also as the administrator, always making myself available for any type of consultation. Going back to the lessons learned, again, providing services for pretty much any youth who is residing in Monterey County or who has been transferred over from another county, and trying to help stabilize them. And we're also trying to make sure that we are trying to do more of the outreach, getting out there before the crisis, trying to provide more interventions and stabilization before the crisis. However, if families can call us in crisis, it doesn't matter if they're, when they call us, we want to provide that support. Other things that we've learned is the importance of being able to do the outreach with our community partners, local law enforcement, and schools. This helps build good collaboration and relationships and trust. We are going out to CIT, crisis intervention trainings for law enforcement, school trainings, whatever we can do to get out there. Also expanding our hours. I think when we started, Ken, you can correct me, the hours were very limited, and crisis can happen at any point. And so we really learning from that and trying to expand those hours to be able to reach those youth who are either being discharged from a psychiatric inpatient hospital on the weekends, and there's no one there to support, that we're there to help with that transition home, or youth who are stepping down from the higher level of placements, or those youth who don't have any services in place, and being able to provide support for the schools. A lot of the time, some of the crisis support hours were in the afternoon, evenings, but this is what we're learning from the data that we're collecting. We're getting calls earlier in the morning that where the schools needed some extra support. We want to stabilize those schools placements as well, and that was important to us. So other things that we learned, and that I was really excited when I came over to Monterey County, is the opportunity to and privilege that we were given to initiate the 5150 and the 5585 holds, which then reduces having to involve law enforcement, and also the trauma that takes place for the children and youth of having to involve them in that whole process. So that has been a different experience, and so far, I think it's working well, and it's been a different experience, and I really appreciated that opportunity. Also, the importance of warm handoffs, being able to collaborate with our partners. We have some really good working relationships with Child and Family Services, behavioral health, probation, and what we're learning is really trying to get ahead of the crisis, doing that preventative work to ensure the stabilization. But if we don't, that's fine. Anybody can call us at any point. And what we're really trying to do is not do a whole lot of phone support. Give us whatever information that we can get and get out there and trying to figure out, not having to go have all these barriers in order to provide the services. That is one big challenge that has happened in some of the other times we've started our mobile crisis. If there's all these strict referral criteria that prevents us from doing our work. Johanna, is there anything that I missed? I was trying to speak really fast to get through this.
No, that sounds good.
Okay, so I want to go ahead and pass it on to, I guess one last thing was also that we're changing with all of our crisis programs is trying to implement a new software where we can start gathering data. And we are taking the information from the FURS proposal and already starting to see the data that needs to be collected or the information in order for that information to be provided to whoever needs that in order to, and the data that we're collecting. So we're excited about that, and hopefully we'll be rolling it out pretty soon. So I'm going to go ahead and pass it on to Ali Spica, who is our director of our rapid response team or crisis services over in San Francisco County.
Thank you, Cece. Yeah, and we can go ahead and dash through some of these slides. I think we're going to skip ahead to maybe about 10 or so until we get to San Francisco. So just to piggyback off of what Cece and Johanna have already built and explained about their mobile response team, we do have a San Francisco team that started about a year ago. And a lot of what had started with San Francisco was in large response to, in preparation from the closure of their child protection center, their CPC or foster care receiving center for youth that had been in operation for about 30 years. And really the intention was trying to bring in a mobile response team for foster youth, really with the idea of prevention and stabilization in mind, and trying to see how we could, as much as possible, try to provide early intervention to help keep kids in their current foster settings. So we have seen a lot and learned a lot over the last year, especially when you tie in throughout California, the barriers to accessing services, including wildfires and the pandemic that we're currently navigating with. Next slide, please. Oh, we're missing some slides. I'm not sure what happened, but I will roll with that. So to give you,
they can go back a couple.
I think one more.
Perfect. Great. Thank you. So to give you a sense of our team makeup is a little different from the Contra Costa and the Monterey teams in that we have a team of 10 counselors, bachelor's level counselors that are all very well trained in crisis intervention and work. 7 of those counselors speak another language other than English, with the majority being Spanish. So we do have a wide net of families that we can serve that speak other languages. We also cover a 90-mile radius, and so that makes us unique in that we have a wide range of places that we can go. And the primary reason for this is that for San Francisco dependents and kids in foster care, about 2/3 roughly of them are placed in either group home settings, STRTPs, or foster care outside of the city and county of San Francisco. We also have all of our phone calls are routed through what Cece mentioned earlier is our rapid response system. That is an internal team within Seneca. That is a multidisciplinary team of very seasoned staff that we have had. It includes licensed clinicians, licensed eligible clinicians, MHRS staff who field and triage and assess every single phone call directly from clients, families. They can get calls from community community members, social workers to consult about a situation that might be happening in the community around what some good next steps might be to provide that crisis stabilization. That rapid response, we call them administrators on call, AOCs, can then triage the call and make the decision about whether in-person support is needed. So from there, they may disperse or dispatch staff depending on what county the call is coming from and what resources are available. For say Contra Costa or Monterey, that would be during their select hours between that 9 a.m. to 10 p.m. range. For something like San Francisco, if it's as early as 8 a.m. and as late as 10 p.m., we would also have our internal mobile response team staff going out to provide that need. If the call comes in after hours, we have an extended larger pool of staff that are on call overnight to meet those needs. So you can see there are very different ways to set up some of these systems of meeting these kids in the community and providing that stabilization support. We're also, one of the things that we're currently learning right now is, given that San Francisco does cover that 90-mile zone or range, we know that that will put us into other regions like Contra Costa, Alameda County, the North Bay. And so we are testing out right now some different strategies as we think about FURS of how we could collaborate and communicate with other teams to see who might be the best team to send out in that moment and how we can look at having a much speedier response for families to receive that support in the moment. And with that, I don't know, Cece or Jahan, if you want to add any other lessons learned that we have had with our mobile response teams.
I would just echo what Ken said around this being this like systemic super glue, and that we really do need collaboration and early warm handoffs.
Yeah, and if I can jump in, we've had the great luck of having really responsive and well integrated partnerships, and as we think about rolling this out, those, and you'll hear this from everybody that's doing this work, are absolutely critical. The other thing is the ability to respond, and we talked about delegated authority or shared authority. Integrated authority is probably a better word to put, because it's never fully delegated. We're always working in partnership with our counties when we do have to make a decision to hospitalize, but we can really minimize unnecessary law enforcement involvement, and that's absolutely critical, because it so often, even with the best trained law enforcement, it becomes a distraction and a source of tremendous anxiety and fear when we have to bring law enforcement into a mental health crisis situation. And so we've really had great fortune across our partnerships to be able to move more and more towards a mental health response instead of a coercive response. And I think the teams have been terrific about that, and very grateful to our county partners for doing that. Marnie, do you have anything to add to that?
No, I'm just excited to see where the program evolves to over the next 6 months. It's really in its infancy right now, but our goals are to have zero barriers to access and really getting out there as quickly as possible to improve the quality of these kids' lives.
Any other team members have any additional comments, or should we can respond to questions now or later?
In the chat. So I'm thinking what we'll do is put a pin in those and come back to them at the end, if that sounds okay to everyone.
Great. Thanks all.
All right. Thank you. So now we're going to turn it over to Tony Rosansky and Sylvia DePorto. They are part of a large team of folks that have been working with several Bay Area counties for a number of months to develop a regional approach for FURS. So Tony or Sylvia, take it away.
Good afternoon, everyone. This is Sylvia DePorto, and I'll just run through our presentation on the Bay Area FURS project. For those of you who don't know me, I am the retired director of San Francisco, and prior to leaving San Francisco, in conjunction with Ken Epstein, the behavioral health director of San Francisco, and Chief Alan Nance, who was the probation chief, we began coordinated Bay Area meetings in conjunction with our other partners across the Bay Area around the continuum of care reform, and trying to work together, because as we know, and I think as Elise said earlier in the presentation, our children are all over the Bay Area, and San Francisco is definitely an export county, so many of their children are not placed in San Francisco, they're placed in the surrounding counties. And so we really wanted to have conversations about how we were going to implement CCR across counties. And one of the things that we felt was critical to continuum of care reform was the mobile response, to be able to help caregivers, youth, and children be able to attain stability in their placements by having access to resources that could help them when they were in a time of crisis. And so we began talking with the Bay Area counties about doing a regional model of the FURS. And knowing that it was in its infancy of development at the state level, our focus had been on a regional model. And many of the counties that obviously Monterey and Contra Costa have been in these discussions in and out. We started with 11 counties. We were down to 7 counties. We've got 4 in for sure right now, with discussions around, hey, we can always expand this to more counties if necessary. But one of the things we really focused on was really looking at the data for each of the counties that wanted to participate, and doing a deep review to see what were the potential numbers that each county might have to serve, and how we would be able to meet that need given the large area of the Bay Area, knowing that there are larger counties in the Bay Area, but there are also smaller counties who were not able to necessarily support a full 24/7 operation alone. That was the challenge for those smaller counties, was how do we develop and sustain a 24/7 operation when maybe we have 10 kids who are going to utilize this service. So partnering with the larger counties really made it more feasible to address the initial volume of response that we would have, especially in the startup. As you see, the numbers seem to be smaller right now. We know that they will grow as people learn about FURS, and as the community knowledge increases, we'll see those numbers pick up. But initially, they're going to be smaller. So we wanted to be able to address that issue. We also realized that in order to do a multiple county project, we really needed to have a governance structure that was in place to really provide oversight and move this model forward. They needed to talk together about how we're going to fund this by multiple counties, how we were going to contract this with multiple counties, how are we going to do provider oversight, how are we going to resolve conflicts and problems that come up. And so we put together a model of a governance structure for the Bay Area counties that will address those issues with a team of people with representatives from each county. We also agreed on, amongst all of the counties that participated, a services model that everybody could agree to around what services would be provided and what would be the focus. That work is continuing. We continue to have these discussions because there is that connection that has to happen with the county agencies. So, how do we make sure that if we have a provider, how do we make sure those connections happen? How do we develop those relationships and make sure they're strong? And how do we make sure that the services that are being provided are followed up on by whoever's involved with that child and that family once the mobile response is no longer responding to that issue? Next slide, please. So just quickly, some of the lessons we've learned so far. County resources vary tremendously in the Bay Area for sure, and I'm sure it does elsewhere. We were very sensitive to the thoughts of the northern smaller counties, and the resources are scarce for them, but also they're so spread far away from each other. And so really thinking and understanding that resources vary. Some counties already have some form of a crisis response, and some don't. Some are reaching beyond the traditional mental health population, and some aren't. So we had to be able to think about, how do we make this all come together, knowing that everybody's in a different place. We knew that FURS reaches a broader population than most counties' current mental health crisis response is serving. And so we have to plan for how do you transition from what you're currently doing to what you want to do in terms of meeting the needs of FURS. We also learned that it's probably a lot easier to do an RFP and select a service provider, because that would be much quicker than trying to do that in-house. Given the complexities of government hiring and staffing and the cost, it would make more sense to select a provider through an RFP process. And that a larger provider could potentially subcontract with other providers across the area, because the area is so expansive that one provider or maybe two providers could utilize other agencies to subcontract and provide those services to families across the region, the Bay Area region, which is quite large. And also we learned that if we're going to do this and really move it forward, we need a lead county. We need one county to take the lead and really move forward the RFP in conjunction with a team of people who are informing that process. So a team of people that are representative from all the different counties, sitting together, coming up with an RFP, and really working together on that contracting process, but maybe having a way to pool funds so that it all funnels through one county, if at all possible. So that's why the governance structure was so critical, to making sure that we could move that forward, and that administration and oversight of this requires that multi-county team. So you got a number of different counties participating who are coming together and saying, we're going to form this governance structure and we're going to move this process forward. So those are some of the lessons that we learned in just trying to move this effort forward. We don't have a program yet. We're still in the development stages with 4 of our counties in the Bay Area, but we're working forward as we speak. So Tony, anything you would like to add?
No, I've answered a couple of the questions in the chat box. There was a question about the population predictions, and we used the help of UC Berkeley and also had an Excel spreadsheet that we can make available that can be used. We don't have a contractor yet, and let's see. I think those would be the only things to add at this point. We aren't operational. It's been a long process, and Alameda will be our lead county. We're hoping for a second lead county, but we don't have that identified yet.
All right. Thank you very much.
Okay. So I see, so this is Lori again. I see some questions coming into the chat. And so I'm just going to give folks a couple of quick updates about some of the resources, and then we will open it up to questions. We have been collecting all of the unanswered questions that are coming into the chat, and so we'll be able to read those off, and the appropriate folks from our programs can answer as appropriate. So we'll get to that in just a moment, but wanted to remind everyone that we do have a couple of documents on the CDSS website for FURS. And if somebody could type that link into the chat, that would be great. The 2 things that are listed here on are the Quick Start Guide, and what that is just a kind of a ready, set, go kind of document for counties to use to begin looking at some of the things you need to develop, the folks that need to be brought to the table, the questions you need to ask yourselves. It's just something to get you started on creation of your plans. And so that's one thing to take advantage of. We also have the county plan framework, which is a document that you may use for your county plan. You can adapt it to what works for your county, or use something else entirely. But it's kind of just a framework outline document that you can use that contains all the required components from the statute. Also seeing that we've got folks asking when they're going to find out what their allocations are. And I actually have an answer for you. The CFL is in its final signature stage, should be out, I would think, in just a few days. But we have provided the numbers to CWDA, and so I believe that can be sent out shortly. And the letter has been given to a number of folks in draft form. So very, very, very soon you will know your allocation amount. Can one of my team type, there you go. There's the link in the chat to the webpage where you can find those documents. Jennifer, any other you want to point before we open it up for the questions? Did I miss anything?
No, I think you got all of the that stuff, and then I just have kind of been keeping a lot of the questions, so let me know when you're ready for me to jump into those.
I think we can go ahead with those. So if you want to go ahead and read the questions, a number of them, thank you for all of the folks who have been answering them in the chat. What we will do is make sure all of the questions that we received today will be taken, and the answers that are in the chat or given verbally, we will add those to our FAQ on FURS, which will also soon be posted on the website. So go ahead, Jennifer.
All right, so I've been keeping track of the questions that were being asked in chat throughout, and then noting the ones that one of our presenters already answered. So thank you to the presenters who were jumping in there and responding to some of the chat questions. I'm going to start with the ones that I didn't see answers for just yet, and then we can loop back to some of the questions that were answered and read those through if time allows. So the first one that I have that I didn't see an answer for yet was someone asked if it would be possible after the webinar to see call trends as the source described and share that out with counties. So I think they were looking for a more specific statistics or numbers based on kind of the verbal report out that you gave. Not to put the source on the spot.
No, it's fine. It's kind of funny. Christina and I and the county, we don't have. I was just saying I sent that question over to our QI folks to see if we can start producing something that's very clear, because we track and we have stuff in Avatar, we have stuff in iCarol, and then we have stuff from our provider, Consolidated Communications. And so what happens is some of those overlap each other, and some so they would be duplicated. And so we've been sort of, I can report like large numbers, but then when you start breaking it down, we haven't been asked to do that, so we haven't spent a whole lot of time doing that. But we'll come up with, we've been working on something that makes it a little more clear in terms of those kind of numbers. And the other thing is, and I think Christina mentioned this, we started off with just foster youth, and I saw Ken's numbers and, the early start, that looks very similar to our first couple months. And then we've kept adding different populations. And so what happens is it sort of resets our data a little bit each time. And I think we were finally in a position right before COVID, where like, okay, this is probably the end of what we're changing, and can we get some numbers, going forward? And then everything got a little bit off kilter with that too. But Yeah, we can see what we can get in terms of visual that makes it a little more clear, and I can share that. I sent it over to my folks that do that sort of thing.
Excellent, thank you. I definitely have seen and heard a lot of questions about approximate numbers, and I think a lot of our counties are craving just any ballpark figures that might help them understand what they can anticipate when FURS gets up and running. Okay, another question that we received.
The one thing I'll say about that on numbers, I think it was Johanna that mentioned this too, and I can't remember. We met with the guy from New Jersey, and he said it took them 5 years to integrate it into New Jersey. It's really about how much can you get this into CFTs and into the hands of social workers for them to actually share with folks. So we found numbers didn't start growing at all until we got that integrated into the system. So, you know.
Excellent, thank you. Okay, I think this question may have been answered, but I didn't want to make any assumptions, so I'm going to just check it. We had a question, what is the breakdown of funding percentage Medi-Cal MHSA? And I think I saw an answer from Tony a while later. Did I get that right? Yes, or David, sorry. David put an answer in the chat of MHSA 80%, CHFFA 15%, and Medi-Cal 5%, anticipating a growth in Medi-Cal. Is there anything to add to that?
This is Diana. I'm going to add to that because this is a piece of ongoing conversation between CWDA and CBHDA. We specifically are asking the state for some guidance on what can be billable because right now it's a little over the map because the populations are different and the counties, and there hasn't been a ton of guidance from DHCS on this issue. And so we know that counties want to ensure that if they are billing to Medi-Cal, that they won't be at risk of an audit or a disallowance on that. And it's also very important for our provider community as well. And so I guess I would just caution, there are percentages floating around in the chat and elsewhere about what's being billed to Medi-Cal, but we're not really comparing apples to apples quite yet. And so we need to do a little bit more work. The associations know that. DSS knows this as well. And so we'll try to get that out to folks as soon as we can.
Yeah. And if I could just add, this is Elia with CBHDA. So along that same line, and obviously we've shared with CWDA our analysis of some of the DSS encounters that are considered FURS encounters, and basically looked at which ones we believed would be Medi-Cal reimbursable in order to support DHCS in giving us that guidance that Diana is talking about. So as we continue to work with DHCS and obviously everybody at DSS, et cetera, we will make sure that folks are informed about that information.
Great, thank you. All right, the next question that we had was for our Seneca folks. What percentage of calls are successfully de-escalated by Seneca and do not ultimately require mobile response?
Contra Costa County's mobile response team has a stabilization rate of 84%.
So just to clarify, that's 84% on average calls that do not require mobile response?
That are stabilized, that do not require any higher level of care, so any law enforcement or any hospitalization.
Excellent.
It's consistent with San Francisco. We're at about 83%.
Excellent.
And for Monterey, we're still pretty new and still gathering, our data, but obviously we're working on that.
This is Kim Suderman from CBHDA Consultant, and actually I was asking what percent of the triage, when you triage calls, what percent required mobile response, not law enforcement and hospitalization, but required the in-person at-home response versus where you could triage and say you could settle down over the phone versus needed an in-person response?
I'm not going to have the exact data for you. I could like loop back to it, but I think that it really depends on what the family is wanting. And so I'm hesitant to kind of say, to kind of be flippant about that number anyways, but yeah.
Okay. Thanks.
And remember too that in these systems we do have the ability to link with RAP and with other services, and so it's not always that a straightforward question. And then in our crisis services out of Willow Rock, if a youth isn't linked, and that's not mobile response, that's a different kind of program, but we have the ability in that program to support a child until we can get them linked. So we try to avoid there being gaps in service when we need ongoing service.
So this is Kim again. So it sounds like you have a combination of the triage, then the mobile response, and then depending on the need, you may link directly to a service because they're already in the system. You may serve and take on opening a case, which is no longer the mobile response, but take on the case until they can be linked to a specific service. So that's several layers of graduated care, it sounds like.
That's exactly right, Kim. And I think that if I heard Dave correctly, it's similar to them too. The idea is that there's always a link, so that you're not just using mobile responses. We're going to go out over and over when there's a clear need for ongoing service.
Right.
Yeah, I would say the same, Ken. We started off with a 2-week. We would open for 2 weeks. And we quickly determined with the county that to make sure there was a full linkage and everybody was up and running, that we had to expand that to 30 days. And it's been, so we'll stay with folks all the way until they've gone to their first appointment, just to make sure that there's no gap.
Okay, great. Thank you.
All right, I think we're back to me, and my apologies, that was my dog. So hopefully he'll cooperate with the next couple questions. Okay. We had a question specifically asking if there are any counties in Southern California considering a regional model. So I don't know if you Southern California counties want to respond in chat. And then sorry, go ahead.
Diana, I was just going to say that I have a question out to Children's Committee about who's thinking about regionalizing. And so I'm still in process of getting responses. So if your county hasn't responded to my email, please do. And then we'll go ahead and share that out. And we're happy to share that out with CDSS and folks that are on the FURS work groups as well.
Excellent. Thank you. We had a question of which Bay Area counties are part of this team. And I think that was for our Bay Area group folks.
Yes, Sylvia or Tony, what are the 4 counties that are left?
With Alameda, Marin, Santa Cruz, and Tony, what's the 4th one?
Well, the remainder are pending the letter, the CFL. So we'll know more specifically once the CFL is released, if we indeed have a 4th or even more.
Okay. So very soon.
Very soon.
Can I mention that this dialogue, this is Ellie again with CBHDA, has made me a little worried about our rural counties because all of the examples are urban areas. And obviously even Southern California, the question that just came is again a more of an urban, with the exception of probably Imperial, well, San Bernardino. Actually, a lot of the counties in the South also have big rural areas, but it is a little interesting that the examples that we're talking about, none of them touch rural. And I do think that DSS, we and CWDA, we probably do need to touch base with our rural folks to see how they're thinking about FURS implementation.
Yeah, can I jump in on that one, because we've thought about this a lot, not just rural, but there are times when urban counties become remote because of traffic, or at least in the past that was true, and we're anticipating that it will be true again. And so we're thinking a lot about hybrid models of telehealth and direct response, and how we can deploy resources in ways that allow you to have more reach, so that you can have timely response, even if you're using that timely response with teams of 2, while one person is driving to do a direct response and the other is using a telehealth response in areas where you have reception. I know in San Bernardino, for example, the size of a small country, where you don't have even necessarily on the road reception, that's not going to work. But I also know that San Bernardino, for example, has used some really interesting remote technology for some of their more hard to reach areas. And so we're thinking a lot about how you can create a more comprehensive system using a hybrid approach. And one of the only silver linings of COVID is that we've gotten a whole lot better at being effective. And by the way, for our youth, unfortunately or fortunately, some of them prefer it. So I think many of you have already found this one out.
I'd also add that we'll be able to really draw on some of the learnings around rural response as our program in Monterey County rolls out, because what a lot of folks might not realize is that while there are a few cities in Monterey that are more urban, from North County to South County, it's a 2-hour drive. And once you leave Salinas, it's an hour and a half to the farthest southern point of our county borders. And that whole hour and a half span is extremely rural and secluded. So we're going to learn a lot as we're really rolling this program out. So I think that we'll have some lessons learned that we could share with rural counties.
Excellent. Okay, we had a question about do you have a sense of the average length of time the de-escalation and triage calls are taking, and then the average length of time the in-person responses are taking?
For our phone support, the way our program is structured for our mobile response team is really to gather as much information and really get out there and provide the intervention and the stabilization. So when we're out there and doing a face-to-face, it could take about an hour and a half, but we also follow through the crisis. So we're not just going out there and doing a triage and doing assessment, initiating a hold, and having them go. We will follow them at times all the way through until they get to psych emergency services or a crisis stabilization unit, to make sure that, we are collaborating with them. So that could sometimes take 4 hours, 5 hours. It just all depends. But the average of to stabilize, and we don't require that probably an hour and a half. Johanna, you can correct me if there's any difference in Contra Costa, but it just all depends. We can stay out there and as long as whatever it takes to stabilize the situation.
Exactly. I would say on average, if it's a pretty cut and dry crisis, it'll be an hour and a half, 2 hours. But if the natural respite doesn't get off of work until 5 p.m. this evening, it makes sense for us to hang out with them and stay there throughout that process. And so there are going to be some outliers around there. And if we're really trying to be family centered, we're going to be creative with the families.
All right, thank you.
Jennifer, I was just wondering, it might have already been answered in the chat, but David or Christina, do you have an average time for the Sacramento responses?
We haven't calculated that. I could probably figure out if we can crunch those numbers, but I will say, just anecdotally, because I browsed through the calls, there's calls that are 5 minutes, and then there's calls that are, an hour. So, and when we go out, it usually means being out for a couple hours at least. And we do have the benefit, of course, other than traffic, we can get most places in the county fairly quickly. But usually it's going to be a couple hours because, and it may end up being often a couple visits, because if we're going to open somebody, we have to do assessments and all kinds of things. And so sometimes there's several follow-up meetings, check-ins, developments of safety plans and those sort of things. But I can't imagine thinking about the last handful of calls out that anybody's out less than 2 hours.
Yeah, I think that's one example of how a crisis call versus a FURS type call, may differ, because it's the stabilization is more lasting to avoid, a higher level of care. So it'll probably be a little bit different depending on the level of crisis.
Yeah. And it's so hard to say, we work with homeless Tay, they're happy to, staff will take them to get something to eat and try to, you could spend quite a lot of time taking them around to different appointments from time to time. We've done just trying to make sure they get connected with housing and other services. And then, sometimes you go out to a family and there's a quick discussion and everything calms down, so it's just, it's all over the place. It's all over the place.
That's helpful. Thank you.
All right, we had a question, I think, to the Bay Area. Can you share your governance structure, particularly how funding is optimized and braided when partnering with another county?
Yes, I actually answered this in the chat, but the braiding and blending, we've really shied away from the financing structure, waiting for the CFL. So except that we would use the normal mechanisms for settlement between counties that exist today. And so, there is definitely a hope to maximize different funding streams, and we will work to do that with the provider. From a governance structure standpoint, though, the governance structure that was established was more of a representative from each county, and the county deciding whether that's a child welfare representative, a behavioral health representative, or a probation representative, and having a single rep that would then make up an operations team. And so that team would be the group that would really work through sort of operational challenges, design, those sorts of things, where then we would also have a steering committee that would meet less frequently to really guide sort of the process and have updates be fed up and down. The heavy lift, though, would definitely be in that more operational aspect. We also are treating the client representative, youth voice, parent voice similarly, that at the steering committee level, there would be participants similar to what the county had described, that I had described earlier. So quarterly meetings that would include the provider, a single lead county that's been identified today, hoping to have a second. But the primary lead county would be the RFP issuer, and then the contract would go from there, and the work would happen primarily behind the scenes. But we have some, just as our work is continuing to develop, we have some refinements to make. And so there's not a document available at this moment, but we do anticipate having that much more formalized now that we're in the go implementation stage.
Excellent, thank you. I think shortly after that question, we had the initiation of the discussion about rural counties and the challenges there, and I think we touched on that already. I did see some responses, talking about getting really creative and doing a robust phone response for those more challenging cases where they're further away, or someone mentioned some weather conditions presenting a challenge as well. I just wanted to throw it out there because there are a number of comments and questions about that. If there were any other tips or suggestions that the presenters would like to share regarding the rural challenges or traffic, weather, you name it.
Excuse me, this is Marilyn Mann from Inyo County. I appreciate the idea of being creative and using technology fully. And I think there are some unique things to working in rural counties, especially isolated ones, that more urban perspectives may not necessarily recognize. We have vast areas without internet service, without technology access, and for us, 4 hours of driving just to get to that area. So regionalization doesn't necessarily answer the question either. That just extends your potentially the response time. So I'm hoping that there could be a small county Q&A kind of period, as well as some discussion around how do we submit a plan that either requests a waiver and or allows for some discussion and around how to mitigate and or allow for certain issues to be addressed differently than they might be on a standardized statewide level. Thank you.
This is Lori. I'll go ahead and try and answer that. We've had a number of questions coming into our mailbox from some smaller counties wanting to set up some more personal TA kind of calls. I do think that's an excellent idea. We have the very, very large TA call last week, but our intention is to keep those going in some way. And so I think that's a really good idea for us to set up something for small counties separately to, really have the opportunity to share those challenges with each other and, come up with some possible solutions. So we will work on that. We'll also, look for the information that Diana has requested about counties are considering a regional approach, and, we can look at that to try and organize some more smaller calls. So we will take that on. Thank you.
Jennifer, I want to jump in also, and Lori, if you don't mind, just because I have noticed that there's a number of questions in the chat about the funding, and CWD has also received that from our counties. And so what we do typically is CWDA works with CDSS on any allocation. So the first funding did go to CDSS, and with the goal of an intent of county social services partnering locally with your probation and behavioral health departments on establishing your local response team. And so the initial funding allocations are essentially all the same across every county, 58 counties, with the exception of LA. So each county will receive about $443,000 in year one, with the exception of LA, which would receive double that amount, so about $887,000. That is subject to change in future years because of a couple of things. One is, as counties establish their programs, we don't know yet what everybody's costs will be. We do know that there are some fixed costs that all counties will have to incur and be incurring, such as starting to get your RFPs out, starting to procure equipment, hiring staff, things that aren't Medicaid or Medi-Cal eligible. But as services start to be delivered, then we will have some ability to draw in more FFP on that. There's also a provision in the law that prevents counties from supplanting existing programs. So we know, and we've heard today, that not all counties have a full FURS program necessarily, and may need to make some accommodations and changes or expansion. But there is specific non-supplantation language in the law that we'll have to account for too. So we'll continue to work with CDSS to fine tune the allocation in future years. So counties are aware of that. There was a question in the chat around Prop 30. Yes, it is a state mandated program. So what Prop 30 provides is that counties are required to deliver the service to the extent funding is provided. So it will have to have that conversation. If funding doesn't completely cover those costs, then we'll have to have those conversations with counties. So again, this is all kind of a work in progress. And wanted to let counties know that information in the CFL will elaborate a bit more about how you claim those dollars. It doesn't cover the regionalization piece. I think there was a question in the chat about how that would work. So we'll have to circle back with DSS to see if we need to issue additional guidance with respect to the regionalization and claiming of those costs.
Diane, I think that reminds me, there are actually coming out, and one is the allocation one that you've seen. I believe the one about that's more specific to claiming does touch on the regional approach, because we did talk about that with our fiscal folks, but I will round back to make sure.
Thank you for taking those questions, Diana, because that was pretty much what I had left on my sheet here was mostly fiscal related questions, and I wasn't going to touch those with the 10-foot pole, so thank you. So I think that brings us through the questions that I caught in chat, and I see that we're really close to time. So Lori, did you want to take it over and close us out?
Sure. So I think this has been a really excellent number of presentations. I think that the conversation has really got folks started and closer to plan development, and hopefully some of the information provided today will answer some of the pending questions you all had at your counties. As I said before, we will take these questions and the answers provided and add them to our FAQ document on the website. So if you forgot what the answer was to one of the questions that came up, you can go back and read it there. I think there's a few more that we probably missed answering that we will try and either reach out to the agencies to answer, or if it's a state or county related question, we'll work with CWDA to get answers to those as well. So look for that. As we did say at the beginning, this has been recorded, so we will, it takes us a little bit of time for recorded webinars to be posted because we do have a number of accessibility hoops to jump through. So we'll do it as quickly as we possibly can, but that will come as soon as we get that part done. And then we have more work groups coming. Look for more invites. And we will definitely work on the ask of getting something together for a discussion with the small counties in particular. So I think that covers everything. As always, questions. Jennifer has put our mailbox again in the chat there. If there's something else, feel free to reach out and we will get your questions answered. So thank you again for your time and have a good rest of your afternoon. Thank you.
Yes, thank you so much. Thank you to all the presenters. That was wonderful.
Definitely.
Have a good day, everyone.